Bharathi and I'm an assistant professor at the Department of Orthodontics. And today I'm going to talk to you about skeletal maturity indicators. The key to any successful orthodontic treatment would be to identify the exact age of an individual and give them age-appropriate kind of treatment. And for that, you need to know the skeletal maturity of an individual. Now, before we go into the topic per se, there are a few terminologies that you'll have to know. There's something called a neural age. Neural age corresponds to the development of neural tissue and the age of the neural tissue. There's something called a mental age, which basically comprises of your intellectual quotient and your emotional quotient and gives you the mental age of an individual. The chronological age. Chronological age, very straightforward. That's what all of us use for communication. The chronological age is from the date you were born till present. That's the chronological age. Then the morphologic age. Morphologic age is more of how your body cells feel, how your body tissues feel. It's a relation of your body cells to their aging process, and most of the time is independent of chronological age. Then you have the sexual age and the dental age. Sexual age corresponds to the age at your sexual maturity. For females, it's a lot more easier to identify their sexual age compared to males. And then you have the dental age. Dental age corresponds to where your teeth erupt and the tooth mineralization, teeth maturation, root formation stages. And then you have the radiological age, which tells you how dense or how radio-opaque your bones are. Now, I've spoken so much about ages. Why is it important? You must know that all these ages correspond or can be interpreted differently for an individual. There is no hard and fast rule that a patient who's 12 years old should have a 12-year dental age, should have the maturity of a 12-year-old, should have the sexual maturity of a 12-year-old. So all these ages can coexist at different stages in an individual. Now, why is this important to us? When we see a patient of 12 walks in, a 12-year-old female versus a 12-year-old male. A 12-year-old female might be far ahead in maturity in terms of be it her skeletal age, be it her mental age, or be it her physical age. A 12-year-old female might have more maturity than a 12-year-old male child in terms of growth. So therefore, it is important to know who is at what stage of growth before we can address them. So a 12-year-old child, girl child, will be treated differently with orthodontics, and a 12-year-old boy child will be treated differently in orthodontics for the same kind of malocclusion. Based on their growth, their treatment modalities are going to differ. So that brings us to skeletal maturity indicators. The skeletal maturity indicators are a component of indicators that you see on different parts of the human skeleton, which tell you at what stage is the individual's growth in. Now, before we go into skeletal maturity indicators, it's prudent to know what growth spurts are. I'm pretty sure growth spurts were dealt with in growth and development, but just to refresh and jog your memory, a growth spurt is a different period in time where the individual's growth is accelerated. You have a sudden increase in that individual's growth. So you have growth spurts just 1 year before birth, 1 year after birth. You have a mixed tension growth spurt that somewhere corresponds to between the ages of 7 to 9 for girls and 8 to 11 for boys. And then you have the prepubertal growth spurt, which is somewhere between 11 to 13 for girls and 14 to 17 or 14 to 16 for boys. Now, what structures are usually used to identify the skeletal maturity or identify the age of an individual? You have different components. At the head and neck region, you can use the skull, you can use the cervical vertebrae. At the upper limb region, you could use your scapulary joints, you can use the elbows, or you can use the entire component of your hand wrist. And the lower limbs, you can use your long bones such as the femur, humerus, knee, ankle, etc. But long bones are not really used in orthodontics because we do not X-ray long bones. So most commonly what we use in orthodontics are the cervical vertebrae and the hand wrist radiographs. Now, the other structures that can be used for skeletal maturity other than cervical vertebrae and hand wrist radiographs include the fusion of the mid-palatal suture, your corpus index, and your tooth mineralization. Now, fusion of mid-palatal suture is a little hard to determine because of the various stages in which the fusion occurs. And your tooth mineralization requires additional sequential radiographs, which are again pose a risk of radiographic exposure. So therefore, we stick to cervical vertebrae and hand wrist radiographs because they're part of our essential diagnostic aids. The first set of diagnostic radiographs are your hand wrist radiographs. Now, hand wrist radiograph, please look at my hand carefully. You have component parts. The wrist is made out of 8 small bones called the carpal bones. These long bones that make up the fingers are the metacarpals, and these tiny bones that make up the different parts of your finger joints are called the phalanges. Now, your hand wrist radiographs is a radiograph that's comprised, usually taken of your left hand, to see the bones at various levels of fusion. Now, the importance is your carpal bones, you usually imagine or you inspect their shape, you inspect the degree of ossification or degree of mineralization of the bone, and the time and order of appearance. Generally, when you see a kid of 12 or see a kid of 11, the carpal bones are most commonly formed and set in form. So therefore, you don't take the carpal bones into consideration. And the other issue with carpal bones are that the radiation is far away from clinical examination. That is, if you're looking at an orthodontic perspective, there's no reason to radiograph your wrist or your hand away. So therefore, they're often not radiographed. The other structures are your metacarpals and your phalanges, of which phalanges are most commonly used, most commonly studied to identify your skeletal maturity. Now, moving on to the phalanges. Phalanges are a type of long bones. As you can see the image on the screen, a long bone has a diaphysis, a metaphysis and an epiphysis. Now, the diaphysis is the long slender part of your bone that makes up for the bulk of your bone. The metaphysis is the little gap between your diaphysis, or is the little space between your diaphysis and your epiphysis. Your epiphysis are the terminal ends of your long bones. Now, each long bone can be studied based on how the diaphysis and epiphysis interact with each other and how the epiphysis grows around between two different long bones. Now, before we go into any of these hand wrist radiographic methods, there's a standard pattern that you need to understand. Your epiphysis initially is short, then it grows a little over and then starts capping the diaphysis of the next bone. So these stages, based on the stage in which they are of the same size, they are shorter or they are capping each other, you have various stages of skeletal maturity. The first kind of hand wrist radiographs are the Bjork, Grave and Brown method. Now in this method, there are 9 different stages of maturity. Each of these stages corresponds to one particular maturity stage wherein you can treat the patient accordingly. So first one, stage 1 is approximately around the ages of 10 to 11 for males and 8 to 8.5 for females. Now in this particular stage, as you can see on the image, the epiphysis and the diaphysis of the proximal phalanx of index finger are equal, meaning which the terminal ends are of equal widths. Neither one is bigger, neither one is smaller. And this stage occurs approximately 3 years before peak pubertal growth spurt. That is, if you see a patient with this stage, stage 1, you know that there's a long time to go before the patient's mandible shows an increase in growth. Likewise, moving on to stage 2, which usually corresponds to the ages of 12 for boys and 8 for females. In this stage, the epiphysis and diaphysis, the middle phalanx of the middle finger, are equal. Initially, we saw the index finger. Now, we're looking at the middle finger. Then comes your stage 3, which is around the ages of 12 for males and 9 to 10 for females. Now, there are a few important points at this stage. 3 areas. So, 1 is the hamular process of the hamate exhibits ossification. Hamate being your carpal, so it exhibits ossification. The second, the ossification of the pisiform, which is also another carpal. And the last one is epiphysis and the diaphysis of the radial bone, which is another long bone. Epiphysis and diaphysis of radius are equal. So we've seen stage 1 with the index finger, stage 2 with the middle finger, and stage 3 with the thumb. Moving on to stage 4, it's around the ages of 13 for boys and 10 for females. 10 to 11 for females, and this stage usually embarks or marks the beginning of the pubertal growth spurt for people. It's characterized by initial mineralization of the ulnar sesamoid. Now the sesamoid is a small round bone, ovoid bone that is seen distal to your thumb. It does not come under the count of carpals, neither does it come under the count of metacarpals. It's a small bone, a spherical bone that helps in the movement of your thumb, and it's seen closer to the radius. So the initial mineralization of the ulnar sesamoid of the thumb corresponds to stage 4, following which there is an increased ossification of the hamular process. The next stage, or the stage 5, is approximately at 14 for males and 11 for females. Now this corresponds to the peak pubertal growth spurt. So far we saw stages that were prepubertal, 3 years prepubertal. We are looking at the first stage that corresponds to exact pubertal growth spurt. Now at this growth spurt, and also remember, so far till up to now stage 4, we saw that the epiphysis and diaphysis were equal in width. At this stage, you will see that the epiphysis starts capping the diaphysis, meaning which the epiphysis is a fibrous band that is growing around the diaphysis, growing over the width of the diaphysis, and will start covering the diaphysis. Now, at stage 6, which is around 15 years for males and 13 years for females, it corresponds to a significant end in the pubertal growth spurt. So stage 5 and 4 are ideal if you want to do a functional treatment. Stage 6 is somewhere towards the end or the end of pubertal growth spurt. So there is a union between the epiphysis and the diaphysis. The previous stage, you saw that the epiphysis was capping over the diaphysis, and in this stage, this fibrous structure becomes ossified and becomes one with the diaphysis, causing a fusion, a bony union of the epiphysis and the diaphysis, indicating an end in the overall growth of that individual. 7th stage corresponds to 15.5 to 16 years in boys and is about 13 to 13.5 years in females, wherein the union of epiphysis and diaphysis of the proximal phalanx of the little finger also happens. And the 8th stage is about 16 years in males and 14 years in females, wherein the union between epiphysis and diaphysis of the middle phalanx of the middle finger is also done. Now remember this carefully, we're talking about the middle phalanx of the middle finger, which also corresponds to MP3, which I will be talking about it in the next couple of assessments. And the last stage, the 9th stage, is around 18 to 19 years in boys and 16 years in female, which is the end of all skeletal growth. Now, beyond which you cannot expect any more growth, and it's time to go into other modalities of treatment if you want to correct a skeletal discrepancy. At this age, all the fingers, all epiphyses, all diaphyses are fused and there's no more scope for growth. Now, the next kind of assessment is the Fishman Skeletal Maturity Indicator, which is a much more simplified version of the previous method, where we use 4 anatomical sites, and these are the thumb, the 3rd finger or your middle finger, the 5th finger, and the radius. And there are 11 discrete sections. Initially we saw 9 sections, now we're seeing about 11 discrete adolescent sections, which can be broadly divided into epiphysis is equal in width to diaphysis, appearance of adductor sesamoid of thumb, capping of epiphysis, and fusion of epiphysis. Now, Fishman's indicators are indicated by SMI, the abbreviation of SMI. So, SMI 1 corresponds to the 3rd finger of proximal phalanx is equal in width between epiphysis and diaphysis. SMI 2 corresponds to the width of epiphysis, which is equivalent to diaphysis in the middle phalanx of the 3rd finger. I understand this can get extremely confusing, but it's a lot more easier when you look at the image and understand. So SMI 3 corresponds to a width of the epiphysis and diaphysis equivalent to each other in the middle phalanx of the 5th finger. So stage 1 and 2 are the middle finger, where we're talking about epiphysis and diaphysis are equal in width, and in the 5th finger you have the epiphysis and diaphysis equal width in SMI 3. Moving on to SMO 4, it corresponds to the appearance of adductor sesamoid, the same sesamoid bone, the same ovoid bone that I was talking about that's near to the thumb. So at SMI 4, the adductor sesamoid begins to appear. Then you have the SMI 5. So up until this stage, SMI 1, 2, 3, remember the epiphysis and diaphysis were equal in width. In SMI4, you had the sesamoid making its first appearance. It's not fully ossified, but it's making an appearance. And once you come to 5, we are talking about capping. So initial widths were equal, then you have the capping. In SMI5, you have the capping of epiphysis in the middle phalanx of the third finger. In 6, you have the same capping seen in the middle phalanx of the fifth finger. And those two, 5 and 6, correspond to capping. Just to recap, SMI 1, 2, 3, epiphysis, diaphysis were equal in width. 4, appearance of adductor sesamoid. 5, 6, capping of epiphysis and diaphysis. And the rest of the stages will talk about complete fusion, meaning beyond which your growth has come down drastically. SMI 8 is wherein there is a fusion of distal phalanx of the third finger. SMI 9, proximal phalanx of the third finger is where you see the fusion in. SMI 10, the middle phalanx of the third finger fuses completely, and in 11, all the bones are fused. The epiphysis, diaphysis of radius is fused, adductor sesamoid is completely ossified, and all growth is complete. Those are the indications of Fishman skeletal maturity indicators. Now, there is an image on your screen which talks about exactly how to see 1 to 11 stages of sesamoid. The next skeletal maturity indicator is again a hand wrist radiograph evaluation, which was given by Hagg and Taranger. It's a lot more simplified than the previous other methods that we saw. In this, we're taking into consideration only 2 fingers, or rather just 1 finger and the radius. First, you look at the middle phalange of the third finger, and then you look at the distal phalange of the third finger and distal epiphysis of radius. Now, this is where the staging comes in terms of MP3F, MP3G. So, like I said, you remember we spoke about MP3, which is the middle phalanx of the third finger. So, here you only need to take a small radiographic image of the middle phalanx of your third finger. You don't need an entire hand wrist, you are only observing the stages of the middle phalanx of your third finger. Now, your MP3F stage is wherein your diaphysis and epiphysis are in the same width, and this is attained before the onset of peak height velocity or peak pubertal velocity, and 40% of individuals might have attained peak height velocity, but usually at this stage you have over 60% of individuals who have not attained peak height velocity. MP3FG stage, that is, this is a stage after the initial stage, wherein you see again epiphysis is as wide as the diaphysis, but there is a distinct medial and lateral curvature or a line that is formed, demarcation at the end borders. So now this should correspond to the capping of the diaphysis. Now let me repeat this again with the image. At MP3FG, you have a distinct right angle demarcation of your epiphysis. This is where the epiphysis is going to grow and start capping your diaphysis. This particular FG stage corresponds to a year before your peak height velocity. The next is your MP3G stage, wherein along with the right angulation, the fibrous band is also starting to thicken. Now, so far we saw only capping, but in this particular MP3 stages, we are also looking at the individual characteristics of what is happening when the epiphysis is starting to cap the diaphysis. So, in the G stage, your sides of the epiphysis will thicken and start capping the metaphysis. The next stage, or the MP3G stage, so far we've only been looking at capping and we've been looking at a broad aspect of equal widths and capping. But in these particular MP3 stages, we will also be seeing what happens to the structure when they start capping. So at MP3FG, you had demarcated right angle borders before starting of capping. But at G stage, you will also see that this fibrous band has started to thicken and has become slightly curved around the diaphysis. This stage corresponds to peak height velocity. The next is the MP3H stage, which is the fusion of the epiphysis and diaphysis, and MP3I stage, which are at the end of growth spurt where everything is fused, adductor sesamoid has appeared and all good. Now this brings me to the second part of our lecture, which is the cervical vertebrae maturity indicators, which are more commonly seen on the lateral skull radiographs or the lateral cephalometric radiographs. Now, your cervical vertebra that you take into consideration are C2, C3 and C4, that is cervical vertebra 2, 3 and 4. One, unfortunately, you cannot see it because it's superimposed by the base of your skull. So we're only looking at bodies of C2, 3 and 4. Now, before we get started, you'll have to understand that the cervical vertebra is a flat bone like this, wherein your height of the vertebra, and then you have a spine, you have a transverse process and a spine. Now we're looking at the height and we're also looking at the lower border. Now initially all your cervical vertebrae are going to be flat. They will not have any curvatures when a child is born. And as the child ages, the vertebrae will change in height, will change in shape, and so on and so forth. So in cervical vertebrae maturity indicators, we have 6 stages starting with initiation, acceleration, transition, deceleration, maturation, and completion. To understand CVMI, we could take the analogy of riding a bike, wherein you start riding, which is initiation. You start your ignition and you decide to ride. So initiation. The second stage is acceleration. You accelerate and you move. You go further somewhere, which brings you to the third stage, which is transition. Transition is you've moved from point A to point B. And then you decelerate. Once you've reached your destination, you slow down, you take a break, and then you come to maturation, where you turn off your engine and wait. And the last stage is completion, wherein you've completed your entire ride. That's how you can understand CVMI very simply. Going on to the stages in particular, stage 1 or the initiation. It is usually corresponding to the beginning of adolescent growth, with over 80 to 100% of adolescent growth left. At this stage, the child is very young, there's a lot of growth left. So the inferior borders of C2, C3 and C4 are extremely flat and there is no change in the vertical height. The vertebrae are generally wedge-shaped and the borders are tapered from anterior to posterior. Moving on to stage 2, which is the acceleration. Now at this stage, maybe they are closer to their pubertal growth spurt. Growth acceleration starts with almost 65 to 85% of growth that can be expected at this stage. There are mild concavities that begin developing at the borders of the inferior borders of C2 and C3, whereas the inferior border of C4 is flat. Previously, you saw all the borders were flat. In this case, C2 and C3 start developing mild concavities, with C4 being completely flat. And bodies of C3 and C4 are horizontal rectangular, meaning which they're wide and flat rectangular. In phase 3 or stage 3, which is the transition phase, you have acceleration of growth towards peak height, and you can expect about 25 to 60% of adolescent growth at this stage. You have distinct concavities in the inferior border of C2 and C3, and there's a mild concavity beginning to develop in the inferior border of C4. C3 and C4 still continue to be rectangular in shape. The fourth stage or the fourth phase of CVMI is the deceleration phase, wherein you have only 10 to 20% of adolescent growth left, beyond which you cannot expect to see much of growth. So ideally, when we are thinking about functional treatment, we would recommend suggesting, or we would suggest starting your treatment between the stages of CVMI 3 and 4. Now in this stage, all your C2, 3 and 4 have distinct concavities, and the biggest change is your vertebrae will start growing in height. Up until now, the vertebrae were flat and rectangular, but from this stage onwards, they start putting on height. They become more square in shape. More marshmallow shaped is the word that we use. So they become more square in shape, increase in height, which also corresponds to an increase in height of the individual. The fifth stage, or the maturation stage, is towards the final maturation of vertebra, wherein barely 5 to 10% of adolescent growth would be left. The concavities on all the inferior borders of C2, 3 and 4 are pronounced, well demarcated, and the bodies of C3 and C4 have increased in height and are nearly square. The last, or the completion stage, corresponds to a completion in growth with no adolescent growth expected. Likewise, deep concavities in the borders of inferior borders of C2, 3 and 4, while 3 and 4 have grown in their full height and are more square or more high rectangular than flat rectangular. Now, the last component of skeletal maturity that we can do in terms is the Demirjian's tooth maturation index. Like I already told you, tooth maturation itself is an indicator of growth development. Of course, it gives you a more reflection of the dental age than the actual physical biological age of an individual, but tooth maturation can also be used as a markation to start your treatment or otherwise. Now, there are 9 stages of de Méridion's indicators. The first is wherein you have a tooth germ. Again, remember, the first stage is demarcated with 0, the tooth germ without signs of calcification. Now remember, because there is no calcification, this is not something you can see on a radiograph. These stages were given from histologic sections, and therefore their applicability in clinical practice is quite limited. Unless and until you start seeing calcifications, you really can't use them in clinical practice or use radiographs. So if it's a histological finding, unfortunately you cannot section a child's jaw. So therefore it's important to remember that only the later stages of de Méridion's index can be evaluated with radiographs. So again, stage 0 or stage O, wherein there's a tooth germ without the signs of calcification. Stage A, there's a calcification of single occlusal points without fusion of different calcifications. So for example, if you could look at the image, at stage A you will have minor radio-opaque spots or calcification spots over the occlusal margin of different teeth. Stage B is wherein these focal mineralization points will come together and the contour of occlusal surface is recognizable. All of these mineralized points will start fusing together and you will be able to demarcate a certain level of occlusal contacts or occlusal contour with the cusp and fossa margin. The next, stage C, is wherein the calcification of crown is complete. So the calcification of enamel is complete and now it's starting, the dentin is starting to form. Stage D, wherein the crown formation is complete up to the cemento-enamel junction. Your dentin enamel is all formed up to the CEJ of the tooth. In stage E, you have root formation that begins to occur, and in stage F, the root length has exceeded the crown. Ideally, your root should be twice or 3 times the size of your crown, and in stage F, the root length has exceeded or has doubled the size of the crown. And in stage G, the root formation is complete, but the apical foramen may remain open. It could be a blunderbuss or an incomplete or a immature apex, but root formation is almost done. And in stage H, the apical foramen is completely closed, meaning which your tooth has completely formed. Now, de Méridion's index, you can use them for canines, molars and incisors. In orthodontics, we would use it for the third molar calcification because it is very easy to identify and it is part of the routine diagnostic examination. You can identify a third molar on your OPG or your lateral ceph, and therefore de Méridion's index can be applied for a third molar. Now, that brings me to the end of important skeletal maturity indicators that we use in day-to-day practice. Please remember, there are varied number of skeletal maturity indicators that you could use, but for the ease of day-to-day practice, these 4, the hand wrist radiographs, CVMIs, tooth maturation, are predominantly used in day-to-day practice. The idea behind identifying your skeletal maturity level is so that you can tailor your treatment, you can customize your orthodontic treatment, be it functional jaw orthopedics, be it a functional appliance, be it orthopedic appliance. You want to do mandibular corrections, you want to do maxillary corrections, or you want to expand, you want to do any change in any dimension of space. It is essential to know the skeletal maturity of an individual. As far as the head and neck goes, your transverse gets done first, following your sagittal and then your vertical. So if you see a patient, you need to know what stage, what treatment has to be done first so that you can achieve good results of your treatment. Thank you.